Hey everyone, welcome back to PodBites, where we break down complex medical topics into bite-sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Lema Sibai, your host for today's episode, and I'm super excited to be joined by Ayah.
Hi, everyone. Thanks, Emma, for that warm introduction, and I'm so excited to be here. Today's episode is about anxiety and mood disorders, and we'll be covering a wide range of topics, including many anxiety disorders like generalized anxiety disorder and agoraphobia, as well as mood disorders like depression. I hope you're strapped in and ready. We're in for quite the ride.
Absolutely, and as always, we'll walk you through each condition with real cases, high-yield tips, and some fun mnemonics to help you remember the details. So without any further ado, let's jump in.
All right, let's start with our first case. Meet patient K, a 32-year-old single woman who's constantly worried about her biological clock and the pressure to start a family. She's been feeling restless, she can't sleep, and she can't seem to turn off the worry no matter what she does. So, Lema, what do you think this could be?
Ooh, she seems quite anxious. How long has she been feeling this way?
Around a year.
This sounds like a classic presentation for Generalized Anxiety Disorder, or GAD.
Exactly. GAD is all about worrying and not the helpful kind that gets you to stop procrastinating. It's excessive and uncontrollable to worry about multiple things lasting for at least 6 months. Here's a fact. It affects 3.1% of people in the US every year, and women are twice as likely to deal with it.
Wow, that's a lot of worry. So excessive worry for at least 6 months. Is there a good way to remember the specific symptoms?
There is. It's one of my personal favorites, actually. It's Watchers. The W stands for worry, which is excessive. The A stands for anxiety, which is difficult to control. T stands for tension in muscles. C stands for concentration issues. H stands for hyperarousal, also known as irritability. E stands for energy loss. R stands for restlessness, and S stands for sleep disturbance.
I'll keep Watchers in mind. Speaking of minds, what's actually going on in the brain during GAD?
Okay, so it's all about an overactive amygdala, the part of the brain that functions like an emotional alarm system. Normally, the prefrontal cortex acts like a manager saying, calm down, it's not that bad. But in GAD, the prefrontal cortex can't keep up, so the alarm just keeps blaring.
Do we have a particular DSM-5 criteria to diagnose it?
We do. Remember Watchers? Well, the criteria will be at least 3 of the letters plus for at least 6 months and on more days than not. Meaning that if we had 7 days, 5 of the 7 days would be when you feel the symptoms.
It must be horrible to deal with. 6 months of worry is a long time. How do we treat these patients?
Well, treatment is pretty straightforward. We would use SSRIs or SNRIs for meds and cognitive behavioral therapy as well. With the right treatment, most people see a significant improvement.
Okay, listeners, here's a pop quiz. Which neurotransmitter is most involved in calming the amygdala in GAD? A, dopamine. B, serotonin. C, glutamate. D, histamine.
And the answer is B, serotonin. That's why SSRIs work so well. They help calm that overactive amygdala.
That was an easy one. All right, let's hop right on to our second case, shall we?
Yes, we shall. All right, let's meet Dr. A 52-year-old doctor who gets these sudden, out-of-nowhere episodes of intense fear. 1 minute, he's fine. The next, he's convinced he's having a heart attack, accompanied with racing heart, chest pain, and trouble breathing.
Given his age, I'd totally run an ECG in the ER thinking that it's a heart attack. Given that this episode is not titled so, why don't you tell us what plagues this doctor?
Feeling like you're having a heart attack is a common feeling for this condition. Dr. A is complaining of panic attacks, where his body hits its internal panic button for no real reason. Given that he reports these as a regular occurrence, this sounds like a panic disorder.
What would cause these attacks in the brain, though?
Norepinephrine is what's responsible. It's released by the locus ceruleus in the brainstem, triggering the classic fight or flight response, racing heart, sweating, all of the whole jazz.
Do we happen to have a mnemonic like we did for GAD?
We do, and it's students. S is for sweating, T is for trembling, U is for unreal feelings, also known as derealization, D is for difficulty breathing, E is for elevated heart rate, N for nausea, T for tingling, and S is for shaking.
All right, listeners, quick quiz. Which neurotransmitter is most responsible for the fight or flight symptoms in panic disorder? A, serotonin. B, norepinephrine, or C, dopamine?
And the answer is B, norepinephrine.
If you got it right, good job. If not, don't panic. See what I did there? There's more where that came from. So, Ayah, before we move on to the second part of this episode, are there any anxiety disorders that we should know about?
We have 2 more to cover, and they're often confused with one another. Agoraphobia and social anxiety disorder. I'll cut right to the chase with some mnemonics. For agoraphobia, it's specifically a fear of situations where escaping might be difficult if panic symptoms occur. To remember the situations or places people avoid, think COPES. C for crowds, O for open spaces, P for public transportation, E for enclosed spaces, and S for standing in line.
So, in a sense, agoraphobia is a fear of feeling fear in a place you can't escape?
Precisely. As for social anxiety disorder, the fear is usually of social humiliation, embarrassment, or rejection. To remember the symptoms of social anxiety, think scared. S for sweating, C for crying or choking feeling, A for avoidance, R for racing heart, E for embarrassment fears, D for dread of social events.
All right, let's wrap things up with a quick recap. Correct me if I'm wrong, Ayah. Starting off with Generalized Anxiety Disorder, GAD, remember the mnemonic, watchers. For the symptoms, worry, anxiety, tension, concentration issues, hyperarousal, energy loss, restlessness, and sleep disturbance. Basically, if you're a watcher of your worries for 6 months or more, it might be a GAD. And don't forget the DSM-5 criteria. At least 3 of the symptoms for at least 6 months.
Nothing to correct there. Perfect. All right. Now moving on to panic disorder. It's all about those sudden intense episodes of fear that feel like a heart attack. To remember the symptoms, think students. S, sweating. T, trembling. U, unreal feelings. D, difficulty breathing. E, elevated heart rate. N, nausea. T, tingling. And S, shaking. And it's all thanks to norepinephrine from the locus coeruleus hitting that panic button.
Now, for agoraphobia, or the fear of being trapped with no escape if a panic attack hits, the mnemonic to remember here is COPES, which stands for crowds, open spaces, public transportation, enclosed spaces, and standing in line.
And then there's social anxiety disorder, SAD, which is the intense fear of being judged or embarrassed in social situations. To remember the symptoms, think scared, which stands for sweating, crying or choking feelings, avoidance, racing heart rate, embarrassment fears, and dread of social events.
Finally, to tie everything together, let's do a review of the neurotransmitters involved. In GAD, there's a depletion of serotonin, which is usually in charge of calming the amygdala. In panic disorder, there's an excess of norepinephrine for that fight or flight response. And in SAD, there's a depletion of serotonin and dopamine, which are usually involved in handling social fears. So just remember, serotonin for calm, norepinephrine for panic, and dopamine for social rewards.
All right, that's it for anxiety disorders. Let's continue with mood disorders. We'll cover everything from major depressive disorder to different types of bipolar disorders. Plus, we've got more mnemonics and practice questions lined up. Why don't I start us off with a case?
I'd ask for you to pause so I can refill my coffee, but you're on a roll, so sure, let's go. You owe me one after the episode, though.
Sure thing, Lema. Let's start with our first case. Meet Mrs. G, a 34-year-old woman who presents with persistent sadness, loss of interest in activities she used to enjoy, and difficulty sleeping and feelings of worthlessness for the past 3 months. She also reports significant weight loss and occasional thoughts of death.
Well, this surely sounds like she's depressed. 8 months is a long time. What condition is this?
So this would be major depressive disorder, or MDD. It's a unipolar depression, meaning it involves only depressive episodes without any manic or hypomanic episodes. It's one of the most common psychiatric disorders, affecting about 20% of the population at some point in their lives. Women are twice as likely to be affected as men, just like with anxiety disorders.
Twice as likely in women is a huge percent. Are there any mnemonics to help us remember the symptoms?
Sure thing. Think SIG E CAPS. S for sleep disturbances, I for interest loss, also known as anhedonia, G for guilt or worthlessness, E for energy loss, C for concentration problems, A for appetite changes, P for psychomotor agitation or retardation, and S for suicidal thoughts.
And what's going on in the brain during MDD?
It's all about the 3 happy messengers: serotonin for mood, norepinephrine for energy, and dopamine for motivation. In MDD, there's a dysfunction in these neurotransmitters and a decreased volume in areas like the prefrontal cortex and the hippocampus. Plus, the amygdala becomes hyperactive, making people more sensitive to stress.
So 2 weeks is going to define the DSM-5 criteria? All right, Ayah. Let's try a practice question. In a patient with MDD, which of the following neurotransmitters is most likely to be dysfunctional? A, glutamate, B, serotonin, C, acetylcholine, or D, GABA?
And the answer is B, serotonin. In MDD, there's often a deficiency of serotonin, which plays a key role in mood regulation. For our next case, we have T, a 28-year-old recent graduate who's been overwhelmed, sad, and hopeless after losing his job. These symptoms started about 3 months ago and are impacting his daily life.
Losing a job is truly a blow. I assume he's having difficulty adjusting?
Correct. Adjustment disorder is like a stress response syndrome. Basically, it's an emotional reaction to a stressor. The key here is that the symptoms start within 3 months of the stressor and resolve within 6 months once the stressor is gone.
So the timeline is the key here.
Exactly. It's all about the 3-6 rule, where symptoms start within 3 months of the stressor and resolve within 6 months after the stressor is gone. One of our earlier patients is actually following up with us. Do you remember Mrs. G?
Yeah, she presented with MDD.
Yup. She's in our clinic now about a year after her original presentation. She reports similar symptoms but says they're less severe. These episodes last for much longer though, and she says she experiences them monthly. What do you think this is?
I'm not too sure. Seems rather persistent.
Dysthymia, or persistent depressive disorder, is like a high-functioning depression. It's less severe than MDD, but it's chronic. Symptoms must last for at least 2 years without a break longer than 2 months.
So, if we were to imagine mood disorders as a spectrum, MDD would be at the far left, mania at the far right, normal in the middle, and dysthymia between major depressive disorder and normal?
Exactly. Many diagrams exist online showing what you've just described. They're incredibly helpful in visualizing mood disorders. All right, why don't we start with our next case?
I'll be sure to check those out after this. Lead the way, Ayah.
Meet P, a 35-year-old accountant who feels depressed and lethargic every winter with increased sleep and appetite.
Every winter, so it's only tied to a specific season?
That's what seasonal affective disorder is, or also known as SAD. It's a subtype of depression that occurs during specific seasons, usually winter, and it's linked to a lack of sunlight, which disrupts melatonin and serotonin balance.
I'm seeing some overlap between these conditions. How do we tell GAD and MDD apart?
Great question. So, for GAD, think what? W-A-T. The W stands for worry, A stands for anxiety, and T for tension. For MDD, think SIG E CAPS. In GAD, worry is about future events, while in MDD, it's about past failures and emotions.
All right, Ayah. We've covered the different types of unipolar disorders, but let's talk about treatment. How do we manage our patients?
So, for unipolar depression, the go-to approach is a combination of medication and psychotherapy. SSRIs like fluoxetine, sertraline, and citalopram are the first choice because they increase serotonin levels with fewer side effects. If SSRIs aren't enough, we move to SNRIs like venlafaxine and duloxetine to boost both serotonin and norepinephrine. For severe or treatment-resistant cases, we consider TCAs, which are tricyclic antidepressants, and MAOIs, which are monoamine oxidase inhibitors, as last-line options due to their side effects.
What if someone doesn't respond to SSRIs or SNRIs? What's next?
Actually, we do something called electroconvulsive therapy, ECT. It's most effective for severe cases, especially if there are psychotic features or suicidal risk. It works by inducing controlled seizures to help reset neurotransmitter balance. For less invasive options, there's transcranial magnetic stimulation, TMS, which targets mood regulation areas in the brain without anesthesia.
And what about psychotherapy? I heard all about it.
There are many types of psychotherapy, but cognitive behavioral therapy, CBT, is the cornerstone. For relationship conflicts, there's interpersonal therapy, IPT, and for emotional regulation, we use dialectical behavioral therapy, DBT. Therapy helps manage triggers and build coping skills for long-term stability.
Surely there must also be some home remedies, no? Like exercise or sleeping well?
You're totally right. Exercise is a big one. In fact, just 30 minutes a few times a week can boost mood. For seasonal affective disorder, SAD, light therapy with a 10,000 lux light box helps regulate serotonin and melatonin levels. Consistent sleep, a balanced diet, and avoiding caffeine and alcohol are also key. However, these remedies are just that, home remedies, and they may not be enough in many cases.
I always hear about physicians who dismiss patients by telling them to just exercise and sleep better. We really do need to keep an open mind. Let's move on down the spectrum now. Why don't we start with our next topic?
Our next case, E, is a 52-year-old woman who recently withdrew her retirement savings to enroll in expensive art lessons overseas. She reports feeling elated, full of energy, and has been sleeping only 2 to 3 hours a night without feeling tired. Her colleagues noticed her talking rapidly, making grandiose plans, and spending excessively.
All of her retirement savings?
Every last penny, Lema.
What would cause a sudden shift in mood?
So, our case is a classic presentation of bipolar 1 disorder. It's characterized by at least one manic episode, which lasts at least 7 days or requires hospitalization due to severe impairment. It's all about manic highs. Think elevated mood, high energy, impulsivity, and decreased need for sleep.
Oh, so the complete other end of the spectrum, the absolute far right. And if you remember, the absolute far left was depression. Any mnemonics?
Absolutely. Think I dig fast. I for impulsivity, D for distractibility, I for indiscretion, which also means risky behavior, G for grandiosity, F for flight of ideas, A for activity increase, S for sleep deficit, and T for talkativeness. Basically, in mania, the brain's accelerator is stuck down.
The accelerator being stuck is a fear of mine. To think that could happen in the brain is wild. But wait, what is happening in the brain during mania?
The answer is glutamate hyperactivity. Too much glutamate causes racing thoughts, impulsivity, and grandiosity. Also, dysregulation in GABA, the calming neurotransmitter, makes things worse.
Oh, so the brake has failed and the accelerator is stuck. So it's all about that excitatory-inhibitory balance. How do we diagnose this?
For diagnosis, look for at least 3 of the following: inflated self-esteem, decreased need for sleep, more talkative than usual, racing thoughts, distractibility, increased goal-directed activity, excessive involvement in risky activities. And don't forget the Young Mania rating scale for a more objective measure.
All right, Ayah. And how do we treat it?
Lithium is the gold standard. It's great for reducing suicide risk and managing both mania and depression. Then we've got anticonvulsants like valproate and lamotrigine. For fast-acting relief, we use atypical antipsychotics like quetiapine and olanzapine to reduce glutamate hyperactivity.
Suicide risk? But these patients are the opposite of depressed. They're like euphoric or something.
A way to think of it is that people with depression would have suicidal thoughts, but they may lack the motivation to go through with it. For patients with mania, motivation and risky behavior is considerably higher, raising the chance for suicide. Our next case is Mr. D, a 30-year-old marketing executive who recently started waking up early, feeling overly productive, and launched 3 new projects at work. His friends noticed he was more talkative and energetic, but not delusional or psychotic.
This seems to be more towards the middle of our spectrum, away from mania. What is this?
This would be bipolar 2. It involves hypomania instead of full-blown mania. The symptoms are the same but less severe, lasting at least 4 days without causing hospitalization or psychosis.
How do we treat these cases?
The treatment is pretty similar to bipolar 1. Mood stabilizers and atypical antipsychotics are key. Lamotrigine is especially effective for depressive episodes without triggering hypomania. A mnemonic to help you memorize the treatment is MOOD. M for mood stabilizers, O for olanzapine, O for ongoing therapy, D for depressive management.
All right, Ayah. Why don't we do some practice questions? During a manic episode in bipolar 1 disorder, which neurotransmitter is most likely to be elevated? A, dopamine, B, GABA, C, acetylcholine, or D, serotonin?
The answer is A, dopamine. elevated dopamine levels are associated with grandiosity, impulsivity, and racing thoughts seen in manic episodes.
Okay, and in bipolar 2 disorder, which of the following is required for a diagnosis? A full manic episode. B, a hypomanic episode in a major depressive episode. C, psychotic symptoms. Or D, rapid cycling.
The answer is B, hypomanic episode and major depressive episode. Bipolar 2 is defined by at least one hypomanic episode and one major depressive episode without full-blown mania or psychosis.
All right, back to the spectrum real quick. I remember seeing something called cyclothymia. Could you tell me more about it?
Okay, so cyclothymia is like a baby bipolar. Mood swings that never reach full mania or major depression. Symptoms must last at least 2 years. Think up, but not too up, down, but not too down.
That's so interesting. And speaking of mood fluctuations, we haven't really talked about triggers yet. What are some things that can actually bring on a manic episode?
So one major trigger is medication. Certain drugs like corticosteroids, some antidepressants, and even stimulants can induce mania in people who are predisposed to bipolar disorder. That's why it's crucial to check for any history of bipolarity before prescribing antidepressants.
Oh, that makes a lot of sense. So we've covered symptoms, diagnosis, and triggers. Now let's talk about treatment. How do we manage these mood swings effectively?
Great question. The cornerstone of treatment of bipolar disorder is mood stabilizers. Lithium is the gold standard. It helps with both mania and depression and even reduces the risks of suicide. If lithium isn't an option, we turn to anticonvulsants like valproate, carbamazepine, and lamotrigine, especially lamotrigine for bipolar depression. For acute manic episodes, atypical antipsychotics like quetiapine, olanzapine, risperidone, and aripiprazole can help stabilize mood quickly.
And what about antidepressants? Can they be used for bipolar depression?
Antidepressants should never be used alone in bipolar disorder because they can actually trigger mania. If prescribed, they must always be paired with a mood stabilizer to prevent that from happening.
Got it. So medication plays a big role. So what about therapy? Is that part of the treatment plan too?
Absolutely. Psychotherapy is essential, especially for long-term management. Cognitive behavioral therapy, CBT, helps patients recognize and manage their triggers and negative thought patterns. Another effective approach is interpersonal and social rhythm therapy, IPSRT, which focuses on maintaining stable daily routines to prevent mood episodes.
Oh, okay. That makes sense. Consistency seems to be key. Are there any lifestyle changes that can also help manage bipolar disorder?
Definitely. Small lifestyle adjustments can make a huge difference. Here are a few. 1. Maintain a regular sleep schedule. It's crucial for mood stability. 2. Keep a mood diary to track triggers and patterns. 3. Limit caffeine and alcohol, as they can exacerbate mood swings. 4. Exercise regularly. It's a natural mood booster.
All right, Ayah, we've covered a lot today, from unipolar disorders like MDD, dysthymia, and SAD to bipolar disorders. How about a quick recap to tie everything together?
Sounds great, Lema. Let's start with unipolar disorders. For major depressive disorder, MDD, the key symptoms to remember are in the mnemonic SIG E CAPS, which stands for sleep changes, interest loss, guilt, energy loss, concentration issues, appetite changes, and psychomotor changes, as well as suicidal thoughts. The treatment focus is on SSRIs and CBT, with ECT as a powerful option for severe cases.
Right, and for dysthymia, it's all about that chronic, low-level depression lasting at least 2 years. The go-to treatment is SSRIs plus long-term CBT with a stable routine.
Exactly. For adjustment disorders with depressed mood, we're looking at symptoms triggered by a stressor, resolving within 6 months once the stressor is removed. Treatment is mainly short-term CBT, meds only if symptoms are severe.
And there's seasonal affective disorder, SAD, that winter blues type of depression. The treatment of choice is light therapy combined with SSRIs and vitamin D supplementation.
Perfect. Now, for bipolar disorders, the key difference between bipolar 1 and bipolar 2 is the severity of elevated mood episodes, mania for bipolar 1 and hypomania for bipolar 2. Mania can cause severe impairments in psychosis, while hypomania is less intense and doesn't involve psychosis.
Got it. And for treatment, it's all about mood stabilizers like lithium and anticonvulsants, plus atypical antipsychotics for managing acute mania, and never use antidepressants alone for bipolar disorder.
Just one last thing. Remember, effective management of mood disorders is all about early diagnosis, the right treatment combo, and consistent follow-up. Understanding the difference between unipolar and bipolar disorders is the first step to getting it right.
And drumroll, please. That's a wrap for today's episode of PodBites. We hope you enjoyed breaking down these mood disorders with us and found our mnemonics and tips helpful. If you like this episode, make sure to give us feedback and follow us so you don't miss any future uploads. In our next episode, we'll dive even deeper into the world of psychiatry, so stay tuned.
Thanks for listening, everyone. Keep those mnemonics handy and keep learning. We'll catch you next time.
All right, take care and stay curious, Ayah. Don't forget the coffee mode.
Of course not.